Second. This. Good evening, everyone. Thank you for joining us today. Today, we are going to talk about prevention of premature blindness in newborns. And we are very privileged to have with us Dr. Subhadra Jalali, who's a consultant ophthalmologist at LV Prasad Eye Institute, but extremely passionate about retinopathy of prematurity. She's been very, very active in this field, working on guidelines and really active. I mean, and you will see during the session how passionate she is. We also have with us Dr. Tejo Pratap Oleti, who's head of neonatology unit at Fernandez hospitals in Hyderabad. And he has also been associated with Patients Engage in the past, sharing articles as well. Am I frozen? Looks like I'm a little frozen.
I think you have kept the screen sharing on. Maybe you can stop the screen sharing if there are no PPTs, that's all.
No, I think there's something else which is causing it's my laptop, which you can hear me, is it?
I can hear you.
We can hear you and we can see you moving. So for
Okay.
us, you are live and alert.
Okay. All right. I will wait for the system to respond. In the meantime, I'd like to say that, Patients Engage has been doing this series with I Hope, Indian health outcomes for public health. And Patients Engage is an online platform which allows people to share their experiences, to learn about management of chronic diseases, but also to look at what can be done to prevent and to improve health outcomes. And I still can't seem to stop the share. So I will leave this for now till the system respond. I think I'll start with you, Dr. Jalali. What is, we talk of premature blindness and we talk of retinopathy of prematurity. Can you kind of explain what the two are and how they are related, and why should we be concerned about it?
So the first incubators in the world in a hospital came in 1941 in Boston Children's Hospital, USA. And in 1942, the first premature blind baby was reported from the same hospital in 1942 by Dr. Terry. So this ROP, or retinopathy of prematurity, which was at that time called retrolental fibroplasia, but now everybody calls it ROP. That means this is a blindness which happens almost exclusively in premature babies, and mostly in babies who are saved through the hospital systems. So we know that a lot of premature babies die. Some of them do survive when they're at home, and we don't have data that they get any ROP, but definitely there is a very close connection between saving newborns in the hospitals and them getting blind. So these babies, when they are born, from the outside, the eye looks normal. So those who are born before their 9th month, so we call that as, those who are less than 35 weeks or those who are less than 2 kg. In our countries, the criteria are different in different countries. But basically, all preterm babies are at risk because their eye organ inside the eye, which is called retina, is not developed. It develops usually by 40 weeks, which is the expected date of delivery. So
Right.
in normal deliveries, the retina is well developed when they are born, but in premature babies, it is not born, and then it goes haywire and creates this blindness.
Right. So, Dr. Tejo, since you are actively working in the neonatology, and I presume you are, your department looks at premature babies, why do you think it's a growing concern in India? Or is it a growing concern?
Okay. So if you look at the number of births that will happen in India and the number of births prematurely born, okay, so we are considered to be one of the highest number of premature births that a country can have. Okay, so around or more than 30 lakh births or 3 million births which are happening in India are premature births. Okay, so premature birth means anybody who is getting born before 37 weeks of gestation, then we will consider them as a premature birth. So whatever the condition right now Dr. Subhadra has told, that is, all these neonates are at risk. The lesser the gestation they will get born, the more will be their risk. So that is one thing. If you look at the ROP's journey, like what Dr. Subhadra told, initially when the incubators and other clinical care started improving, so ROP was only known in industrialized countries where they were saving these babies who were smaller.
Right.
So then they realized that there is a condition and how to decrease the incidence. They started improving their care, and then it has decreased. Now again, there is a surge in ROP because now many countries, including India, has invested a lot of money into the newborn care, especially in the premature care of premature babies. Okay, like if you look at Indian scenario, around near to 1,000 SNCUs are there, which are called as special newborn care units. In all these cases, these babies are getting treated. So the survival has improved tremendously. Okay.
Right.
But at the same time, when this happens, the incidence of ROP will go little on the higher side. Okay. And also now, even in the industrial country also, there is a little slight increase in the incidence of ROP because they started saving very early gestation of the babies, like 23 weeks, 24 weeks, 25 weeks, and 26 weeks. These babies are at more risk of ROP. So as the time grows, now, as the number of birth grows, the number of premature births will increase, and the care has improved in a good way that we are happy that survival is happening. But at the same time, some deficiencies in the quality and some deficiencies in the baby itself, okay, so that can increase the risk of ROP basically. Okay, so we need to see that all these babies are at risk, and then we need to screen them. As Dr. Subhadra told, the child will go into blindness if you don't detect them early and treat. Okay, so we need to look at the manpower to screening, and we need to look at the other things. I think we'll do it in the next. Yeah, sure. Thank you.
I see a couple of hands up. If you have any questions, and if you're on Zoom, please post the questions in the Q&A box. And I think you can enable captions. So if you need that, you can do that as well. We will try and incorporate the questions in the discussion or at the end of the discussion. So if there's any other comments that you want to pass, please do pass them, because I see a couple of hands up. So Dr. Jalali, we've talked of kind of the main causes of ROP, and Dr. Tejo started talking about screening, but can you talk through in terms of what can be done to prevent ROP in the first place?
So of course, to prevent ROP, the first would be prevent premature births. So any country who is saving newborns, especially these preterms, is going to have ROP. So we are not saying don't save these newborns. If the babies die, you have no ROP.
Correct.
So yeah, but we want to save every newborn, whether they are premature or not. We want to save every IVF baby, every surrogacy baby. These are the vulnerable babies. So the first would be, can we prevent premature births? So I think I'm not very qualified to talk about this, but my experience, both as a mother of a preterm baby and as a doctor who's been treating for 30 years, I can say that, the teenage pregnancies, the maternal malnutrition, very early marriage, still we have a lot of, girls who are married off very early, or they have very early pregnancy, and then the mother's nutrition, almost 80% women in our country are anemic at the time of pregnancy, and they have multiple pregnancies, one after the other, or, all these IVF assisted fertilization techniques. So, some of the people who are highly educated, they postpone their pregnancy, and they think that, IVF and, putting their eggs in freezer is the answer, and it is going to give them very nice babies. So these are the, elderly mothers who then get premature births. So, every advancement in development and technology comes with very high risk. So there's something
Right.
natural, and natural is that women should have their children between, let's say, 25 to 30, 32 years of age. That is the best age for healthy babies, for healthy mothers. But, on both sides of the spectrum, in many places, this is not followed. If mothers are drug abusers, alcohol, tobacco takers, that also increases the prematurity. But overall, even with all these factors, there are still some unknown factors why premature births have increased worldwide. Some people think it is chemicals in our food chain. Some people think it is the climate change which is affecting, but certainly the number of preterm deliveries and the surviving preterms has increased. So while the science has advanced, I think still we are far away from preventing premature births, and actually they are increasing because of all this assisted fertilization that is happening. But at least those factors that we can control in our, girls, in our daughters, I think we should consider those
Right.
to reduce the
Uh,
premature births.
right. Right. And Dr. Tejo, as someone who is more into management of premature babies, what is the advice you and your colleagues give to mothers who are pregnant, and during their pregnancy, what can they do to prevent premature births, if there is anything they can do?
Obviously, I think Dr. Subhadra has started already saying that ideal age, and then what are the habits that you should not have, and then what are the habits you should have it. Okay, so at the same time, I will like request all the parents not to go for the multiple pregnancy unless it is a spontaneous one, because multiple pregnancy will definitely will increase the number of chances of your premature birth will be increased. So that is one thing. And second thing is that when the mother is having certain factors which will determine that that baby can born premature, like mother having some chronic disorder, health illness issues. Okay, and then during pregnancy only obstetric illness can occur, like pregnancy induced hypertension. Okay, so which is one of the things which is considered to be more common in India compared to Western countries. So there also the chances of premature birth will increase. Then they need good antenatal care setups. And then third one is that small for gestational age babies. That means that the fetuses who have intrauterine growth retardation. So they are not catching up to their growth potential. So all these certain cases where which mother is more prone to premature birth, they all have to be screened and kept in a earmarked centers where the facilities are available. And wherever there is a treatment, you should try to decrease the severity of the illness so that you can prolong the pregnancy. Okay, so that is also an important thing. And some of the screenings like cervical length screening has been shown to increase the chances of if they have the long cervical length or then short cervical length, then they are more prone for the premature birth. So all they have some procedures which can prevent the premature birth. And then once you know that you have higher chance for the premature birth, so try to go a center nearby where have facility for both mother and newborn to get take care. So ideally in these babies, so the prevention aspect will start from antenatally. Okay, so first thing is that refer to a good center. Second, 2-3 important uh, interventions which have been shown to have some effect on the postnatal course are antenatal steroids. I think government has taken it up as a very serious thing and has given even the ANM's responsibility to give a first dose of steroid if they are seeing a mother with a premature who is in the labor of premature. Okay, so it has been propagated. Previously, our coverage was very less, but now the coverage is good. Second one is that those who have rupture of membranes before labor onset, that means that some of them will land up in the hospital with a rupture of membranes, though they don't have the onset of labor. So in those cases, the early onset infection chances in the babies are very higher. Already you have prematurity and then early onset infection, the higher chances for the ROP. So the people who first see them should have screen for the leaking and then start an antibiotic so that they will not land up in the baby with the infection. And good care in the first few minutes and hour this is considered to be one of the good uh, primary responsibility of the person who is attending. Some of the things like oxygen usage, restricted oxygen usage, oxygen targeting, saturation targeting. Okay, so we need to target the saturations of the newborn baby between 91 to 95%. So you should not go up. If you're going up, then there is a higher chance for that baby to have the ROP. Then prevention of infections. That is also an important thing. Okay, so all these things will come under postnatal care, which are good nutrition, all these things where we need to have facility for these things, then they have to go. So these are the parents' responsibilities, that those who are couples' responsibility, they have to go to a center where both the facilities are there. I think we'll discuss some of the postnatal interventions which have potential impact on the ROP later on. But
I
at least
to add one point here. We did one study. It was done in Fernandez Hospital before Tejo joined there. We found that babies who are born to anemic mothers had a more worse developed retina than those who were born to mothers who were not anemic or who had good weight gain. So so previously people did not think that mother's health would affect the baby's eye. But now we know very well that if the mother doesn't get good diet and has low hemoglobin or does not gain good weight during pregnancy, which will transfer into what dignity she is getting, what food she is getting, what rest she is getting, what type of work she is doing. So just I want to emphasize that just working is not going to cause premature birth. You can stop working and you should work. That keeps your body pliable. So don't think that if I do bed rest, then I will not get premature birth. That's a myth. But the health of the mother and periodic monitoring of that health and ensuring that she gets enough proteins, nutrition, and all the good care, because whatever good care happens not only during pregnancy but even before getting pregnant, that will really influence what the child is born with, not only for the eyes but for the intellect and so many other things. So this is something which is not emphasized enough in our care. We are very happy that we are going to get a baby in the house, but those details of the mother's health need to be emphasized.
Correct.
Pre-pregnancy counseling.
Preconception. Preconception and pre-pregnancy counseling, I think, is extremely important. And in a country like ours, where anemia in women, young women, is such a at such a high rate, then I think what you've said is extremely important for people to consider as well. Apart from other health conditions that we are also now seeing an increase of.
One small point, sorry, is important that if somebody had premature deliveries earlier, or abortions or multiple things, many times our women or families are hesitant to get the fetal autopsy done or to find out the cause, and they just let it go that, okay, this year we lost the baby, next year we'll get again. I think that time, if there was a premature birth or a fetal death or something, or abnormal fetus, a detailed fetal medicine specialist or somebody should do an autopsy, should find out what has happened, because they are at very high risk of second, third time same thing happening. And if you don't treat at that time, then they just land up into the labor room with one more pregnancy which is premature.
Even the placenta characteristics also determines a lot of things. Okay, so some of them do not have the courage to go for the fetal autopsy, but at least if they can give the consent for the placental biopsies and placental autopsy, lot of things we can try to look at it. That freedom has to be given, and then again the costing and other things, expertise, other things will come later. But I think we need to look at all these aspects.
Give that information that placental biopsy and fetal autopsies do make a difference to what is going to happen next.
Right. Thank you. So in terms of you said that there are all these challenges. Where are we today if you look at the landscape in India in terms of the distribution of ROP incidents across the country, or across the different type of socioeconomic classes, or across different urban-rural divide? What is the landscape of it, and where do we go from there?
Yeah, so when I started my work 25 years ago in 1998, the ROP was confined to the rich or the middle income people, what we call as aspirational generations, from only the metro cities. So we would see only from Chennai, Calcutta, Delhi, Bombay. And as Hyderabad was, going into the next phase of the Cyberabad and the soft
Right.
industry, and also, the NICU started mushrooming, and all these issues of late pregnancy, IVF, and all started, and we started seeing ROP. But today, in last 20 years, the scene has completely changed, because now our infant mortality or neonatal mortality rates are going down, and these are part of our sustainable development goals. We
Correct.
want to save those 3 4 5 million children of India who used to die within 1 month of birth or within 24 hours of birth. So the government and the private sector has set up, as Tejo said, more than 1,000 special care newborn units and NICU all over. And now the disease of ROP has spread to the rural areas, to districts, to any center. So as I said, the history is very clear. If an incubator is set up, within 1 year, you will start seeing the blind. So anywhere, if the incubator is set up and the eye specialist is not there every week to check these babies' eyes, in a year, you will start seeing. When I started my work in Hyderabad, I went to a lot of NICUs. All the new NICUs were here. Each one of them refused me. They said, we don't have ROP. Our babies are fine. Why do you want to come and tell us that these babies will become blind? And in 2 years, there were so many disasters that blind children came. So it's not that somebody is trying to blame game. It's not a blame to the parents or to the NICU or to the machinery or to the technology. This is what happens, that the disease will come. So today, now we see that almost 60% patients are coming from all the so-called Bimaru states, because they are getting better. They are improving their health care. They are improving their neonatal care. The babies are being survived. But the ROP care is, a little far behind. So we are seeing it gone into rural areas and gone into the districts. And in the cities, in the central part of cities, I think most of it is controlled. Everybody has geared up and there are good services available. But again, in the suburbs of the urban areas, the services are not that good.
Right. Right. So in terms of, we've talked of what needs to be done before a woman gets pregnant, during pregnancy, but assuming that the child is born premature, what are the protocols and what is the, what should they be looking at? Dr. Tejo, first, if you can go.
Yeah. So as I said, that will start from the immediately after birth. Okay. So for any premature morbidity to decrease, we should have the planning before delivery only. And then immediately after birth, if the baby is crying, allow the delayed cord clamping. That means that if the pulsations are there and then the baby is crying, at least after a minute, you have to cut the cord, because some amount of blood transfusion will occur from the placenta to the baby. That will help in initial stabilization of the baby better. And then if the baby requires any breathing support, because many of these babies are having immature lungs.
Right.
Okay. Immature lungs means there is a substance called surfactant which will be there in the lungs, which is not produced in the early gestations, which will start producing a little later. Okay. So then for all these babies, we should give a little supports. So always we need to give the breathing support. As much as possible, try to avoid invasive ventilation. That means that putting an endotracheal tube and then giving the ventilation. Try to give the CPAP or non-invasive ventilation, other techniques. And then if the baby requires any oxygen, we need to use the blender. Blenders are not very costly. We have to invest in that blender. And then try to titrate the oxygen as much as possible, so that, because oxygen is considered to be one of the major culprit for ROP. And then high oxygen and even very low oxygen also is detrimental. We need to remember that we need to target saturations properly between 91 to 95%. This has to be the message that we have to go. There is a concept called oxygen with love also, owl concept. So people started putting a owl in front of all the incubators, and their targets will be written. I am so and so, my gestation is this, target my saturation between these two. So like that oxygen with love concept has come. Then some of the cost-effective interventions are also there, like using exclusively the mother's own milk. Okay. So because this has been shown to have a lot of potential growth factors which will influence the retinal vessel growth. thereby preventing the ROP. Okay.
Right.
So whenever the mother's own milk is not available, you can take the donor milk. Pasteurized donor milk is available. Human milk banks are nowadays available in many of the states. So you can use the pasteurized donor milk. Then target the growth properly, because we have the growth charts which are there for the postnatal. So try to titrate the growth with a good nutrients so that baby will not go into growth failure. Okay, because the postnatal growth failure also has been told that it is a major risk factor for the ROP. Then especially in our countries, the infections. Okay,
Right.
we need to have aseptic precautions have to be followed both by the clinical care team and those who are visiting also. And we should have a good housekeeping practices where we can maintain the aseptic precautions and try to decrease the incidence of infection in these babies, so that again, infection also, because it will cause increase in the ROP for the baby. Okay,
Right.
and two other things which are important is that one is the blood transfusions. Okay, so nowadays it is told that restrictive blood transfusion, unnecessary usage of blood transfusions, which again can lead to increase in the ROP. Some of the other drugs which have been tried, like vitamin E supplementation and other major nutrients, have not shown much of the improvement. Still, they are in the experimental phases. But at least these things, like easily doable things, like oxygen saturation targeting, good ventilation techniques, restrictive
Right.
blood transfusion policy, and then infection control, use of mother's own milk has been shown to decrease the ROP in a good way, because this doesn't require much money. Okay,
Right.
but it requires
Right.
more commitment both from the clinical team and the non-clinical team, and even the parental and family involvement. So now parents involvement also has to be there in the care. Nowadays the family centric concept has been promoted in a good way from both the country government also, and across in all the units, because that also has been shown to have some developmentally supportive care and developmentally supportive field for the baby. These all have been shown to decrease the ROP. So I can emphasize only on these things rather than the more extensive gadgets or anything. That's what I can say.
Right. Right. Dr. Subhadra, from at what stages should uh, people like yourselves be brought in to, do you need to be brought in to examine the baby, and how often and up till what stage?
Yeah, so we already heard that, I call this Six Sigma care of the baby, that the eye specialist should definitely be asked to see the baby between 20 to 30 days of birth.
Right.
Is din roshni ke, just like do boon zindagi ke. So for our country, we coined this slogan, everybody knows do boon zindagi ke, to take care of your arms and legs and not have polio. Same way, tis din roshni ke, that within 30 days, don't cross 30 days. Uh, if the child is very small, we usually prefer to see them by 20 days, that is 3 weeks of birth. And so on the day of birth itself, there should be a sticker, there should be a band, there should be a label put on that file or on the mother's hand that this is the day you have to have an eye checkup done. So this is missing. Sometimes it's very casual, because we hear from parents, they say that doctor told eye check kara lena. Just go
Just
and
get
get
it
one
done.
eye, just get it done. So, but it was not told when,
When?
where. Even like, one educated family, I saw that discharge slip, it was mentioned, go for eye checkup on Thursday. So when they came, they didn't go. They were late. I said, why did you go late? They said it was not mentioned this Thursday.
Just
Thursday. So we thought it is any Thursday. So, so the clear communication, the clear information that, what date they have to go for eye checkup, that should be very clear. It's very simple. Whatever is the birth date, the 1 month is the cutoff. So please get the eye checkup done. Now, what happens is that in some places, the eye doctor can come and see. Okay, if the baby is not discharged till that time, or baby is sick, there is no issue. The sick
Right.
baby on ventilator, baby on oxygen, baby receiving transfusion, even all these babies, very safely they can undergo eye examination, which takes only 10 minutes by the doctor coming to the NICU. So it is the duty of the pediatrician there to call the eye specialist and say, this baby cannot be discharged, cannot come to your clinic, you need to come here. Now, if the baby is discharged to home, then they can come from there. But this teeth thin Roshni is very sacrosanct because what happens if we see them at that time, then one, we can modify the disease by what Tejo said. We can improve their nutrition, their weight, we can see what is the oxygen they are getting, we can see that they are not having breathing problems, they don't have any infection. So we can control. So the ROP can be decreased or it may not happen if we, control at that time. And then if we see ROP and we treat it there, it's like,
Right.
I always say ROP is like a fire. If you can detect the fire at the very earliest, then the damage will be less, the control will be easier. So sometimes parents say, why can't we come at 35 days? If I say 35 days, then you will come at 40 days. So that is the tendency. So we are saying deadline, don't go beyond 30 days. It is not safe for your baby to postpone. Sometimes the father is not there, he has gone out, the mother says, I could not go alone. No, please get somebody and take. उस बच्चे को definitely 30 दिन के अंदर अंदर आंख जरूर चेक कराएं, उसमें लेट नहीं करें, उससे आपके बच्चे में सीरियस अंधापन आ सकता है. अगर आप टाइम से चेक करेंगे तो ट्रीटमेंट भी इजी रहेगा, कॉस्ट भी उसका कम रहेगा और आपके बच्चे की आंख की रोशनी भी अच्छी तरह से बचाई जा सकती है. एवरी डे आफ्टर 30 days the treatment becomes complicated, it becomes worse, the outcomes are bad, and then you will go into a lot of costly treatments which will still not give you that result.
The outcomes you're looking for. Right.
So
So
we
Dr.
need,
Subhadra, sorry, go ahead,
yeah,
Dr.
we
Tejo.
just need to emphasize, I think, all the healthcare personnel who are treating these premature neonates, put it in the right word, as Dr. Subhadra is saying. Just writing the prescription may not be that
Need to
sufficient.
emphasize the
Yeah.
importance of it.
Why
Right?
we need, because that's a permanent thing.
Correct.
Blindness is a permanent thing. You cannot able to reverse it. We don't have a eye transplant till now. I don't know when it can come, but at least when we have that in hand, the screening will help it. Definitely we need to promote more screenings in this.
Right.
And the incidents, I think we haven't discussed, but at least see, even in a good center, like I'm telling about our own incidents. So at least 600 to 800 babies will get screened every year for the ROP, because that much babies are who are born less than 35 to 35 weeks and less than 2 kilo, which is the guidelines from 34 weeks and 2 kilos, which is the guidelines from Government of India. So even in those cases, with a good care, still 5-6 babies will require a laser therapy or some other medications for the ROP. So that means that who is that 6? I don't know. So
Right.
I need to screen 600 babies, definitely. For all 600 to 800 babies, definitely for all these things. So we need to try to promote that the babies needs it. Okay.
Right.
This therapy, this screening is required. That's what I can say.
Right. Thank you. And Dr. Subhadra, in terms of treatment, I know Dr. Tejo just mentioned laser, but what are the other, is laser the only option, or what are the treatment protocols, assuming a child is diagnosed with the
So
ROP?
if the child has ROP, there are two types of ROP. One is what we call aggressive or severe, and one is mild. If it is severe, it requires treatment within 24 to 48 hours. We should not delay. It needs immediate treatment because these eyes progress day by day, hour by hour, and they need really immediate treatment. Most of these are babies who are very sick, or they were not getting weight, or they were less than 30 weeks. Sometimes we see in bigger babies also. So if we say it is, and it is called as aggressive ROP, if we see aggressive ROP, which has a very characteristic round blood vessels in the eye, then it needs immediate treatment. And the other group, which has like mild ROP, these babies need further checkup. So it's not a one-time checkup. If it's mild ROP, then we give medical treatment, and medical treatment can prevent many of these babies from progressing. But they need to be checked every 2 weeks. So the medical treatment we give is exactly what Tejo said. We ensure that there is weight gain, there is no anemia in the baby. If there's an infection or nasal block, that is to be corrected. So those things, so we advise all those things. And we found that, 60-70% babies, even with early ROP and mild ROP, they go away completely in 4 to 6 weeks. So every 2 weeks we check. The other group which will progress, they will need treatment. So there are 3 types of treatment that we give. One, for aggressive babies, nowadays we give injections in the eye. These are anti-VEGF injections, various types of injections are there. So we must give those injections in a very aseptic, of course, conditions. And after the injection, for next 6 to 8 hours, the baby needs to be monitored, because sometimes they can have little pain, or very rarely, it's not common. Usually these are very safe injections, there are not much side effects, but sometimes babies can get breathing problem or feeding difficulty. So after the injection, the babies must be kept under observation of the pediatricians, or I mean, they can go home, but they should be ready to go to a pediatrician emergency department if there is any feeding or breathing issue. The other group of babies who don't have aggressive disease, we give them laser. So laser is some rays of light, just like we give for diabetic patients, we give. So in babies who receive injections, they need further checkup at least for a year. So it's a prolonged treatment, and some of these babies after injection may need more injection or more laser. Many of them, about 30% of them, would need laser in future. So there's no problem with that. So these treatments, laser or laser with injection and the medical treatment side by side, as I told, this cures completely almost 90% of the babies. Some babies have very severe disease, it progresses, then we need to do emergency surgery, which is called vitrectomy. And this surgery is available in few places. The injections and lasers are more readily available in many places. The surgery requires high risk anesthesia. But again, it's quite safe. Most of the babies do very well with surgery. The parents are very worried when we tell them that, your 1 kg baby who's just come out of NICU needs a surgery, and we take high risk consent. High risk consent doesn't mean baby is going to die. High risk consent means that the whole team, the parents, the doctors, the hospital, they know that we are treading a difficult path. We have to work together to make the baby see and survive. So fortunately, very good protocols are there. There are good surgeons around the country who are able to handle this along with the pediatricians team.
Right. Thank you. And Dr. Tejo, in terms of the government coverage, or, the schemes that are there for people, what's the coverage for the treatment, the screening first, and then I guess Dr. Subhadra can talk a little bit more about both the screening from a retina's perspective, but also the treatment perspective.
So I think 10 years back now, the RBSK program has been started. So it was looking at mainly the deformations, developmental delays, and other disabilities. Okay. So one of the things that has been percolated there is that you have to, even the ROP screening also has to be there as a part of this the disability screening. And okay. But unfortunately, not all the district centers where the DEACs, that is the district early intervention centers, have not been into fully functional, which should have an ophthalmologist who is trained in screening. If that could have been there, at least in each district, we would have had a good screening center. Still, it's a little undercovered. That is one program. If the government scales up more vigorously, I think we should be in a good position. So that is one thing that we should look for it. Okay. So overall coverage, I think we can say that around 30 to 40%. That's what previous studies and other things have been shown, especially in the rural. The main problem is there. Many of them at least are getting screened once, but again, the disease won't stop with the one screening. We can able to say in the first screening that where is the retina mature, what is the level of the retinal maturity, and then after how many days they have to come back. So parents sometimes complain that baby's eye, you are touching it, and then other things. We try to tell them that screening is only 1-2 minutes job. But if you don't do it, as Dr. Subhadra told, that the fire will go on and then the blindness will occur. It's only that 2 minutes where we have to take the pain. Some of the time side effects will be there. In any procedure, that's what happens. Even sometimes baby can have a little apneas also. But we tell them that you have to stay back for some time and then the baby will improve. It's only transient pain that will give rise to these type of things. But they have to come back for the second screening also. Again, government is trying to keep a track of all these babies, but again, tracing the babies till the grassroots level is a major challenge. while you are doing it. So that is the major problem. Not more than 30 to 50% it is happening. In urban centers, it is happening in a good way, but definitely in the rural and district level centers, the screenings are not happening too good.
Right, right.
Yeah, Dr. Subhadra, you want to add something?
Yeah, so there are two aspects. We'll first talk about the advocacy and policy. We'll talk about awareness later. So if there are people here who are bureaucrats or who have access to policymakers, bureaucrats, health commissioners, or whosoever collectors, whosoever are involved, please give this message that create facilitation of private-public partnerships if there is no government doctor available. But make sure either government doctor or the RBSK, that is Rashtriya Bal Swasthya Karikram, and the National Health Mission, they allow public-private partnerships. Many of my colleagues, they have had difficulty in getting those permissions. Even we sometimes repeatedly go to the, the health departments and try to get permission. So the babies will not wait. They become blind. Okay, I think together as collective, it is our responsibility to see that in addition to surviving babies, we have babies who can see the world. We all should have vision. Visionary people are required at that level, that don't delay, try to get those, try to look around you and see the NICU or the SNCU where I am, is there an eye specialist coming there every week? Or is there a program? So that is very important for us, that the program is set up. Currently, even in suburbs of big cities and in many of the hospitals, both in government and in private, it is not there. The eye screening is not there. See, the coverage for vaccination is there in almost every center.
Correct.
We don't hear that there's a hospital where children are born and there's no vaccination program. So fortunately for us, now vaccination program is embedded both in public and in doctors. But you're saving the leg, you need to save the eye also. But the eye program is lacking, or it's very sparse. It's not there at all in many places, and even where it is, people are not very clear what has to be done, how vigorously it has to be done. So those things are required. So please set up those systems so that at the policy level, on the paper it is there in many places. So that we are very fortunate. We worked on that. Tejo's group, our group, and whole country did work on the national task force, and the guidelines are there. They are available on the website. So government has made, the central government has worked on that and passed the ROP guidelines. And not only ROP guidelines, it is combined with newborn eye health guidelines, because newborns also need eye checkup at birth. We didn't talk about that much, but India has the largest number of blind babies in the world, not only from ROP. Now we are becoming ROP capital also, but other diseases like congenital cataract, congenital glaucoma, cerebral visual impairment. There's so many other eye diseases which we can detect at birth, within 24 hours of birth, and they can be very effectively treated. So that group is already there. So these guidelines are already there, but health being a state subject, every state has to formulate the guidelines for this particular condition. And if they don't put it in their program, they will not get the central government funds. So they have to put it in their program and, be there. And the policymakers and people who are bureaucrats who have the power to change lives of people, they can do it. So we've seen very good examples around the world, and even in our state of Telangana and many other places where the governments have been very active and they have put the program in place. It needs to be put in every place where a newborn baby is being taken care of.
Dr. Subhadra, you want to add the tele-ROP models where there is no access?
So we also now have very good cameras. So we have started that in places where the doctor cannot go. And this is already being run in Karnataka, called the Kid Drop model by Dr. Anand Vinekar, and there are other people also running it, where you have cameras. These cameras, the nurses or the technicians can be trained in the NICU itself. So the government can help to provide these cameras and the training and the program and the maintenance of these cameras. So in the NICU itself, the nurses can take the pictures of the eye, and these can be transmitted through teleconsult to specialists, or even very soon the nurses and the doctors also learn how to look at these images. They are not difficult to interpret, to say that this retina is normal and this is abnormal, or this baby needs to be referred. So the number of times that the patient has to go from one center to another can reduce the number of visits and going from one hospital to other. Fortunately, the government is providing the money support So I think, because I do get parents who say that we went and we didn't take treatment because it was not affordable. So I want to inform everybody that though there are centers where we will charge or people will charge, but if somebody cannot afford, please try to find where they can get free treatment. Free treatments are freely available in most places through RBSK funds, through National Program for Control of Blindness funds, through a lot of charitable organizations, including LV Prasad Institute, where we do free treatment for anybody who cannot afford, through Arogyashri, Ayushman Bharat, different ways. Definitely, there's no reason that somebody should not take treatment for want of money in today's era. It's only a question of, accessing. Even we've had patients who were tweeted to the chief minister that, my baby is going blind. So immediately the minister has responded and transported those babies. So everybody has to be active and not sit at home, or even some doctor is charging you, the patient can't afford. Guide them where they have to go for free treatment. Don't let them come after 3-4 months when the child is blind.
Right. Just before we continue, there's one question. I think this is for you, Dr. Tejo. Do you prescribe lutein and zeaxanthin-based formula to mother where premature births are expected or child born prematurely?
Literally saying, and scientifically, we do not prescribe it. So that's what I can say. So the scientifically proven efficacious models for prevention of premature birth are very few. Unfortunately, we do not have many interventions also. Like if the mother had a premature pregnancy previously and then short cervix is there, they can go for the stitch. Suture they can do for the cervical stitching can be done. And some of the specific group where the progesterone supplementation, vaginal supplementation will help. So these two are the major things that have been shown. But definitely the screening and then putting them a good antenatal care, there only it will have. Unfortunately, not many nutritional supplements or any drugs that have shown much benefit in terms of reduction of the prematurity.
Yeah, I just want to add that, I don't want the audience or the parents to, go with the impression that it's a disaster if you have a premature birth. Mother of a premature child and he's just passed from Ahmedabad. Okay. Most of the premature births, they will do extremely well. What is required is to go through proper protocols, through safe management of these children, follow all the protocols, make sure that if you have a preterm birth, you get the best care and you understand. And, I have had parents who say, we Google search, nobody told us about ROP, but once I had a premature birth, I Google searched what do premature births mean, and then I found this video on ROP. So find out about your child's condition, talk about it. Your child is going to be really well if they are taken care of. Most of the premature births do well. Some of them don't do well, but most of them do well. So don't be hyper.
Don't be disheartened and
don't. That's why I told the incidents also. So it's not too common, but we need screening. That's the main
important. I've seen mothers getting depressed when we tell them they have ROP or they have premature births. Then what happens is that the milk doesn't come. Then the baby doesn't thrive if the mother is worried. Sometimes mothers ask me, what more, doctor, can I do for my baby? I said, just talk to them, hold them close, tell them you're going to be fine. The team is with you. These things are very important. The kangaroo mother care, we didn't talk about the full support to that baby by the family. And sometimes the families don't support, they leave them alone. If the baby has ROP, they abandon those mothers. So full family support, if it comes, and full enthusiasm that, okay, there's a problem, but we are all going to together work at it. It really helps and the babies do really well.
One question, Dr. Subhadra, because when we were talking a couple of days back as well, you talked of, children whom you've seen at an older age, right? And can you talk us through a little bit of the symptoms of ROP if they're not diagnosed in a child? And is there anything that can still be done for them?
So sometimes, as I said, that, they were not screened, or they were screened and they didn't follow, or the treatment didn't work, whatever. So some of the signs, which are the earliest sign, is that the child starts having shaking of the eyes. They will not look straight. They will move their eyes up, down. And normally by 6 weeks of birth, 6 to 8 weeks of birth, if you move a toy or a light in front of a child's eye, they should fixate completely. They should immediately look at it and move their eyes along with that. But these children, they will just look here, there. It will seem that they're seeing, but actually they're not seeing because they're not following correctly. That's one of the earliest signs. The second is that there may be a white color which may, reflect from the eye. So it's the mothers who notice that first, that, something is wrong with my child's eye, some color I'm seeing. And then the family or the doctors, even sometimes the doctors, they tell, oh, there's nothing. No, if the mother is complaining that I'm noticing something, please send them to eye specialist immediately. Some of these children, they will poke their eye. They will keep their finger like that. And they'll not remove. Or they will keep both the hands like that. Or they will try to keep their hands on the mother's shoulder, their eyes on the mother's shoulder. So these are signs that there's something seriously wrong. Not only ROP, there are other diseases also. But anything seriously wrong in the eye, the child will start keeping hands. Though the parents will think the child is just having some irritation, allergy, maybe he's just rubbing his eyes. No child should touch their eyes. Okay, if any child just keeps on doing that, that is the earliest sign that there's something seriously wrong in the eye. And then, of course, that, sometimes these children, they have neurodevelopmental delay, so they don't hold their neck, or they don't smile, or they don't contract. So so sometimes they get referred to neurologist. Their brain scan is done that maybe their brain is abnormal, but nobody checks their eyes. So if a child has sort of been diagnosed that they have a developmental delay or it's not achieving its milestones, then immediate eye checkup should be done if it was not done earlier, because the problem may be in the eye and seeing.
Right.
So these are some of the common signs. The older children, of course, they will sometimes complain that, they can't see well, or in the school they are picked up that they are not reading the board. And at that time, the milder cases get diagnosed. They sometimes have high glass power, or their retina is bad. So they can see, but they can't see very well. And this gets picked up. Or sometimes the parents tell us, like we say, why you didn't go for eye checkup? They said, oh, we noticed our child getting things close, but we thought it's just a habit. So some of these children will, when they are seeing something, they will always try to bring the toffee closer or that book closer, or, they will close their eyes in bright light. They will not be comfortable in bright light. So any eye symptom, anything, or they will get squint. Sometimes they get lazy, the cross eyes, what we call as Bengapan or Melakanu. So anything abnormal in the baby's eyes, the parents should not think that this is normal, or the child is, he will grow out of it, or this is something which will happen later. Immediately complete eye checkup must be done if the parents notice anything abnormal in the function or the color or the movement of the eyes.
Right. And sorry, at that stage, if they do find something, and yes, it got missed out earlier, is it still treatable? Are there any options there?
So it depends. So we call these as stage 4 and stage 5 ROP. So some of the stage 4 ROP, they can be helped to improve their function by glasses, or by magnifiers and low vision aids, or by voice activated systems. And so, yes, but they will be at risk of losing vision later in life, but we give them the precautions. So some management can be given. But stage 5, there is not much treatment. We do operate. After surgery, some of these children are able to see colors or make out day and light and all. So that's very minimal. They are still blind. But stage 5 children, mostly we send to rehabilitation centers, where in today's world, they can go to normal schools, in integrated schools, where they learn Braille in one class, and rest of the studies they do with normal children. So it depends on the intellectual content of the child, what type of training and schooling is given. But yes, no child is left behind. We do ensure that every child gets the chance to have its full potential. The parents do get depressed when they know that their child is blind, and that this blind could have been prevented. But anyway, there's no point in crying on what has happened. We do ensure that many of these children, they really do well. Once the parents accept that this is what it is going to be, and then they go through rehabilitation program, and they also turn out to be amazing people.
Right. And the question we received, does ROP run in families? Is it inherited risk?
ROP doesn't run in families. As I said, this is not an ancient disease. It's a totally medical issue, where incubator care and surviving of these babies leads. There's another disease which we call as FEBR, which is like a cousin of ROP. It's exactly like ROP, but that is genetic, that is familial. It resembles ROP. It looks like ROP. It smells like ROP. but it is not ROP. Usually we see it in little bigger babies. But if we see a ROP baby where there's family history, then we think of the genetic disease, and that has a different management protocol. But there it's very important to say that there's something genetic, because then the next child can also get it, whether they are preterm or not preterm. But ROP per se is having very little influence of genetics. Most of it is the care.
Right. So, we are reaching the last 5 to 10 minutes of the program. If there are any questions from anybody, please do type that in. Dr. Tejo, from your perspective, if we were to summarize and say that, what is the one change that you would want to see? Or what are the 3 changes you would want to see?
Okay. I think definitely the screening part, Dr. Subhadra will cover. So from my side, if first thing is that we should not be fearing about prematurity. That's the important thing. Getting born premature is not a curse of the baby, but doing best during both the perinatal period and the postnatal period. Perinatal period is that antenatal steroids and then giving the antibiotics for the mother with the rupture of membranes early, and then taking a good care, which 6 to 8 aspects, which I have told, if you concentrate that with a good family-centric approach, kangaroo mother care, and the parents sometimes ask us what I can do. I only tell, keep your tensions aside, bring the positivity inside. When you come to the NSU, touch the baby with the NSU, in the NSU with the positivity, and that positivity will improve your milk output. That will get transmitted to the baby. Both the positivity and the growth of that baby will be good in terms of both the brain development and the retina development will be much better. That's what I can say. So at least from the parental perspective, that positive touch and the more interaction with the baby postnatally, along with mother's own milk, if she can produce and then give it to the baby, that's a major thing that we can anticipate and advocate for the parents who got the baby born premature. That's what I can say.
Right. Thank you. Dr. Subhadra?
So one thing I want to change is, I want my Prime Minister to say in Man Ki Baat, "Tis din Roshni ke." I want Amitabh Bachchan to say "Tis din Roshni ke," just with the same passion and vigor that he said "Do Boon Zindi ke." I want every SNCU to have big posters saying "Apne bacche ki aankh check karao" in the local language within 30 days. I want people to go out with placards on the Children's Day, on the World Prematurity Day, which is on 17th of November, and shout loud. I want all people here who are listening to this seminar to put out on your social media that, Tis Din Roshni Ke, it is very, very important. People don't know about it. I want, before I die, to see that every parent who has a baby born, whether it is premature or not, knows about eye care, just like they know about polio drops and, vaccination. Then only we can say that our children and our country has vision.
Just on that, right, what is the level of training and awareness among the Anganwadi workers, the ANMs, ASHA workers on ROP? Is there any data on that?
So you should ask the question, what is the awareness amongst doctors? Right. So it is not in the curriculum of many doctors. ROP is still not in the curriculum of MBBS doctors, just like the polio is. ROP is not in the curriculum of school students where vaccination is. It is not in the curriculum of nurses. It is not in the curriculum of ASHA workers. It is just come into the curriculum of PGs in ophthalmologies and PGs in pediatrics. Still, a lot of pediatricians don't know about it. It's only the neonatologists, who are sort of the higher super specialists, who know about it. So, to reach the Anganwadi workers, it is going to be still a lot of time, unless I said that, there is a campaign like polio. Unless the government makes it happen, that all the Anganwadi, and it is doable. It's not that it is not doable. All these workers do come in every month for some training or the other. Just, 2-3 hours or 1 hour of seminar on the RP that we have to talk today. Just this information that these babies can go blind, they need checkup. It will have a huge impact on reducing the blindness. Today, Every day, at least 8 to 10 mothers come with their blind babies to my clinic. I cannot do anything for them.
Right. Okay. On that very sobering note, but also I think a call to action that, each one of us can make a difference. Each one of us, as Dr. Subhadra said, can spread the word and can understand that, ROP is important. Eye care is important even for small babies and not just for later, once you start going to school. So I think it's important, and I think she has a nice slogan of Tis Din Roshni Ke. So I think it's catchy enough for all of us to remember as well. And as she reminded us, 17th November is Prematurity Day, and that's why we are doing this discussion on ROP this month as well. So it is, as I think both Dr. Tejo and Dr. Subhadra has said, that premature babies are doing better. They are surviving. They are, they're getting adequate care. But let's also look, make sure that they do not become blind. They don't lose their vision.
So I think just last comment.
Sure.
I think as next week is the World Prematurity Day is coming. I think everyone in the vicinity, if you have any baby who has born premature, just ask them these questions, whether the eye is screened or not. And then other important screenings are that hearing screening. Hearing screening has to be done. Third one is that hypothyroidism. Okay, because 1 in 800 babies in our vicinity are having with the congenital hypothyroidism. There are many other screenings, but at least these 3 screenings, if they can do well, and then many of the major morbidity and developmental delays, we will be able to prevent it. So there are many other screenings for the premature babies, developmental assessment, tone assessment, all those things will come later. But at least these 3, if we can emphasize that eye, hearing, and the thyroid, hypothyroidism, obviously the brain development and other things are also important, but these 3 are very important. One, because once the timeline goes, you cannot do anything.
All the material for social media, for videos, it is available on YouTube, it is available on the net, it will be available on our LVPEI website, it is available with the government RBSK website. So there's no dearth of the material that you need to use. And anybody has any doubts, please feel free to write to us.
Yeah.
The slogans on Prematurity Day will be on the small things only for the small babies, but they have a bigger impact. So let's do that small things and make everyone have a big impact in their lives.
Right. Yes. Thank you. Thank you so much, Dr. Subhadra, Jalali, and Dr. Tejo Pratap for joining us today and for talking about a topic which is, I have personally learned so much in today's session. So thank you so much. And we will, as we said, spread the word on, and we don't talk enough. We talk about premature babies in general, but we don't talk about the challenges of specific issues. So thank you so much once again for joining us today.
Thank you.
And thank you to the audience.
Thank you.
I hope for making this happen. Thank you for this wonderful platform.
Thank
you. Thank you.